Good afternoon, everybody. On behalf of IFKF-WKA, the International Federation of Kidney Foundations World Kidney Alliance, I welcome all of you for our webinar. This has been organized by Dina, our Secretary of the IFKF-WKA, and it's on kidney disease on the global public health agenda. No population should be left behind. I think there are a lot of people who are left behind because of this, because of their financial situation, the income group that they come from, and also the backgrounds that they come from. So I think this is a very important discussion that we're having today. And I really want to thank Dr. Ranga, Dr. Efima, Dr. Natasha, and also Dr. Valerie and Dina for being here today. Before we start, I would just like to maintain 1 minute silence in prayer for our beloved treasurer, IFKF-WKA treasurer, Mr. Carlos Castro, whom we lost a few days ago. He was heading the Kidney Foundation in Mexico, and he was doing a fantastic job. He was an inspiration and a beacon of light to everybody. Because he was into care of patient care, of organ donation, advocacy, and so much more. So may his soul rest in peace. Thank you, everybody. I also ask for world peace today to the universe and the cosmos and all the gods. Thank you. Dina, over to you, if you could take over. Thank you.
Thank you, Lata. And hello, everyone. I am Dina Abdulatif, and I'm a nephrologist, consultant nephrology from Cairo University Hospital in Cairo, Egypt. And I'm the Secretary General of the IFKF-WKA, the International Federation of Kidney Foundations, the World Kidney Alliance. And today I'm so happy that I'm so honored to have all our speakers and moderators with us today. And let me, in the beginning, just share my screen. So this is our agenda for today. And can you see my screen now? Yeah.
Yes.
Okay, so we will have 3 speakers with us today. We'll have Ifeoma Ulassi, and she will be speaking today about the one big issue, the CKD screening in the low resource settings. And we have Ranga Wijenwikrama talking about the CKD-U and who is at risk, and the burden of AKI in the resource-limited settings by Natasha Srisawat from Thailand. And Valerie and myself will be moderating these sessions, and we'll be expecting your questions all through the webinar, and we'll have a discussion in the end. So for the sake of the time, I believe we will have to move. First, Valerie, you start, and then we will move for the first speaker. Valerie?
So thank you very much, Dina, and welcome everybody. Thank you for joining. And hopefully we can record this, because I'm sure that these talks are going to be extremely interesting and extremely important for advocacy. I think that's what a lot of all of this is about. So the first speaker is Professor Ifeoma Ulassi, who is a professor of nephrology and medicine from Nigeria. She is a very well-known international nephrologist, has been very prominent also in the World Kidney Day Steering Committee, as well as in the ISN, where she's the deputy chair, soon to be chair of the advocacy working group. Extremely active in Africa, leader in Nigeria. And she herself, I've recently learned, was actually screening people well before World Kidney Day even was developed. So screening, I think, is in her bones and in her blood. And we look forward to hearing today from her. Thank you, Ifeoma.
Thank you so very much. Am I sharing the screen?
And Ifeoma, let me stop my sharing first. Please share your screen.
I should share my screen?
Now it's starting. Now, yes.
Okay. Can you see it?
Yes.
You can
Yes,
see it
we
now?
can.
You just make it a show.
Okay. Yeah, I'm going to make it slideshow right away. So you're good with it, right?
Yes, we can see it.
Okay, so thank you very much. Good afternoon, good morning, good evening, everyone, because I believe people are watching from all over the world. And thank you for the introduction, my dear friends, Valerie and Dina and Lata. I'm indeed very happy to be giving this talk today because screening is one thing we in low and middle income countries should not ever not give up. Yes, and I'm talking about the one big issue, CKD screening in low resource settings. And I'm of College of Medicine, University of Nigeria, and I also practice in another teaching hospital in a different town. And I say no population should be left behind. So I'm going to take us through why, who, when, where, what, how, and then conclude. So why should we be screening? We should be screening because we know that NCDs are all over the whole place, and NCDs account for 71 or 74% of deaths, and which equates to about 41 million. And out of this, 15 million are premature deaths, and 85% occur in low and middle income countries. And while we know that the big 5 diseases, as it were, are reducing, CKD is rising so fast. And most of this rises in the low and middle income countries. That is where we are talking about today. And we know that globally, CKD is about 80% in low and middle income countries, while the poultry 20% in other parts of the world. And also AKI is so rife in low and middle income countries. You can see the prevalence in the low and middle income countries of 14 to 36% versus 9.1% globally. And the age of onset is another problem. Starts in people of 20 years and maybe even earlier in people of African descent, while it's in older people in other populations. Then when we look at, I've already mentioned this, that while others are going down, CKD is coming up. And the other important thing is that a 40-year-old man who is on dialysis has his life expectancy as short as that of a 75-year-old man, which is one thing we want to avoid. And when you look at the cost of renal replacement therapy, or even CKD in general, is so much. You can look at the American average for salary for an average person in America, average person, so to speak, is 60K. And they look at all the things concerning CKD compared to other diseases. You can see CKD is so expensive. And then, of course, if you come to the low and middle income countries, we bear the huge brunt. All the catastrophic health expenditure occurs in our population. You can see, and renal disease is very responsible for most of it as against other diseases. And of course, it occurs more in, can you see my cursor? It occurs more in the low and middle income countries than any other country. So, and KDIGO, realizing that this is very important, that is kidney disease improving global outcomes, decided to have a controversy conference to see how they can bring out the important things concerning screening and early intervention. So they called the conference in 2019, and they titled it Early Identification and Intervention in CKD. And the consensus emerged that CKD screening coupled with risk stratification and treatment should be implemented immediately for high-risk persons, and that this should ideally occur in primary or community care settings with tailoring to local context. So if your local context is like lower and middle income countries where you don't know people that have the risk factors, you can go on and do a population-wide screen if you can afford it, or you can target people through their lab results, or target them opportunistic screening. If a patient comes into your clinic, you can actually screen the patient for kidney disease, even if the presentation is not for kidney disease. So talking about kidney disease, should we or should we not screen? We know that we should screen, because when we look at the screening principles adopted by WHO, CKD checks all the boxes. So this is not meant for you to read, just for you to know that for the 10 itemized things in the principles, CKD checks all of it. So we can screen for CKD. So that is not a contention anymore. But the contention now is, okay, like I was saying, all the scholars agree, or most scholars agree, that CKD fulfills the WHO criteria for screening. But the final details of whom to screen, how to screen, then how to treat are contentious. But concerning the contentions now, we have a publication which tells us that indeed, general population can be screened and it is cost effective. By the study done by Cusick et al. In the in the US, they found out that urinary albumin-based screening for CKD, followed by treatment with the ACEIs or ARBs and SGLT2 inhibitors, is cost effective. So if anybody tells you that population-wide screening is not cost effective, we should take it with a pinch of salt, because it depends on the context and it depends on where. Screening refers, it's good to define screening so that we understand what we are talking about. Screening refers to detecting previously unrecognized or subclinical diseases among asymptomatic individuals, because we all know that at the early stages, stage 1, stage 2, and some part of stage 3, people don't have symptoms. So we need to actually bring them out. And that is when we need to intervene. That's the paper by the Cusick and co. So I think it was 2 years ago or last year, 2023, we wrote this paper on screening for kidney disease in low and middle income countries. It was headed by Robert. I'm sure most of us know Robert. And in the screening, we emphasized that considering the high burden of CKD on patients, society, and health systems, strategies to improve screening for kidney disease should be a priority. And then looking at the who we should screen. In the Western world, they talk about hypertension, diabetes, and stuff. But we add on and the age of the patient. We also add on HIV infection. But indeed, the screening should be extended to far more than these 4. Because depending on where you're coming from, some things are more important. I remember, was it 2 years ago, I talked in India about NDTs, that is the neglected tropical diseases and kidney disease. And in some places, neglected tropical diseases are such a problem. So for those places, you can think of population-wide screening for the people. And other forms of demographic problems we have, like poor socioeconomic conditions, work-related conditions that predispose people to CKD. So population-based screening can be used to identify those at risk. We can also do population-wide screening, as I have convinced you, I believe. We can also do opportunistic screening, where we are screening people as part of a routine medical visit or other purposes. I always make sure that when I see these children entering school or starting work, and they come for medical screening for work or entering school, I make sure I screen for kidney disease, because that is where you pick them. And also the risk scores and risk assessments should be done before medical tests. That is, if you're doing a population-wide screening or if you're doing a population-based screening. And this just shows some of the risk factors. So how do we screen? These are the things we brought out in that same paper for screening in low and middle income countries. We highlighted screening for albumin. You can use the albumin creatinine ratio to detect albuminuria, and then using creatinine to estimate the glomerular filtration rate. But it's important to note that if you cannot do albumin-creatinine ratio, you can do the strips urinalysis. Unfortunately, some people have looked at how to convert one to the other. I will show it in the next slide. This shows that if you are able to use cystatin C, you can use it, but cystatin C and creatinine, they all have their problems with different things, either making them more or making them less. But cystatin C is thought to be more sensitive than and specific than creatinine. So this is the equivalence for the different albuminuria grades. You can see what it is in KDIGO categorization. And then when you have albumin creatinine ratio, and when you have milligram per excretion rate, or when you have milligram per gram, or when you have urine protein creatinine ratio, milligram per gram, or when you do your dipstick. So you can use this. If somebody has 2+ in dipstick, it's equivalent to greater than 300 milligram per gram. So when you have finished screening, what do you now do? You need to categorize the people. You need to stage them and know where they belong and what to do with them. In some cases, if they are found to be to have a high normal glomerular filtration rate and have low albumin excretion, which means they are normal, then you can give them maybe next year or 2 years or 3 years or 5 years, depending on how old the patient is. But if they happen to belong to where they need to be treated, like is a group 3B and has maybe 300 milligram per gram, that person needs to be treated. So they refer, or you treat them, or you refer them, depending on where the patient is being seen. If it's in the community where you do not, where maybe a health community health worker is doing the screening, you move the patient on to the primary healthcare center where the doctor sees, and if it's beyond what the doctor can do, he refers the patient out. And these numbers show how often you can screen the patient per year, or the person per year. So looking at the KDIGO controversies conclusions, they have 13 conclusions of what can be done and who can be screened. And you can see them on the screen: populations for CKD screening, risk stratification and treatment, measurements for early CKD, what you can use, which we have discussed, whether you are going to use creatinine or cystatin C, or urine albumin creatinine ratio, and all that. Interventions for CKD, what you can do. One basic thing I make sure I do to my people, first and foremost, is to ask them to drink a lot of water. You know, we live in the tropics and it's quite hot and dry. Make sure you take 3-4 liters of water a day. These are basic things. I mean, you don't need much. You don't need to pay for it, so to speak. If you have hypertension, make sure you take your medications for hypertension, and then avoid smoking and all the basic things we talk about in World Kidney Day, the 8 golden rules of World Kidney Day. They are basic. Some of them you don't need payments for them, things you can tell them to do, and they avoid having kidney disease. So now let's come to the strategies. There are several strategies we can use. And like I said, this is a slide I used in my presentation in 2015, and I still find it relevant now. So for the screening, one size indeed does not fit all. You can have 2 different types of strategies going on in the same country, depending on where you are. Sorry about that. So depending on where you are, so you can have a whole population screening, population-wide, or target population screening, or high-risk population, or you can use the healthcare structure like they do in the UK. They use the healthcare structure. I've talked about opportunistic screening. And one important screening we should do, because I keep saying kidney disease, we shouldn't go it alone. We can hinge our screening to other screenings like hypertension, cholesterol screening, or DM, or HIV. All you need to do is that urine screen and creatinine, and you're on with it. So this diagram from Vasalotti's paper shows what the people you can screen, and also shows stratification of the people, and then shows what you can do for patient safety, what you can do for CKD management, and where you should refer. So the other models as well, there's a simple model that we use in our own study, in our own paper by Robert again. This is quite simple. The people you should screen, remember the other infections and all I've talked about. If the screening, you can use dipstick, and then if this stick says positive, you can move on at this point to do the urine albumin creatinine ratio and all that, and so forth and so on. You move it on until it gets to the stage where the patient maybe need to be referred. Similarly, we also have another paper. I happen to be also in this paper. This was from the position paper from AFRAN, where they showed the screening and what we can do for patients, including the treatments we can at least give for patients where they are identified, from the lifestyle changes to diabetic management, hypertension management, and all that. So what are the challenges? Obviously, there are so many challenges in our climes. The weak health systems, low literacy levels, some people don't even understand what you're talking about, inadequate health funding, poor health-seeking behavior. Many people are there in the community. I remember when I did my screening in 2006, I actually found a lady with stage 5 CKD in the community. She had never been to hospital. And of course, by the time I came the second or third week, she was gone. She was dead because, of course, she couldn't afford to go to hospital, even though she was referred. It made me feel so bad. We really need to do a lot more in our countries. Lack of skilled health force. At times, of course, we have to task shift. But when we task shift, we must make sure the people are properly trained, because if you don't train them properly, they add to the problem. We are not talking of just we are talking of quality to what we are doing, not just that people are screened. There has to be quality. And of course, political will is one thing we lack in our countries. We need a lot more political will to have screening done in our different countries. This I put in here because I've been talking to some group. They have, and I hear they have piloted in India. They have this IFKF, where they integrated digital kidney care tool to improve lives for kidney patients worldwide. What they do is that they detect, they help treat, and predict. And I understand, and they support as well. I understand that a year's treatment can be as low as $30 or even low dollars for 1 year's treatment for one person. I don't know the full details, but I felt that this should be mentioned, because if we have such a program, we can get our governments to buy into it, and then we can spread it all over. And when we have it all over, it'll probably come down from $30 to $10. So I saw this when I was preparing my talk, and I felt that we should do a lot more in Africa. Asia has recommendations for early detection for chronic kidney disease. So Dina, I'm saying that as for AFRAN, we should be challenged. Both of us are in the prevention and advocacy committee. We should be challenged to come up with something, put together a group of people so that we can work on this and come up with our recommendations for Africa. I didn't want us to forget these other considerations. We must also remember that these things start from the cradle to the grave. The risk factors start from the cradle to the grave. So we should have that factor that in. Similarly, this was from the KDIGO CKD guidelines, from the cradle to the grave. We should factor all the risk factors in. So in concluding, and screening for kidney disease should be priority in low and middle income countries, because early intervention reduces the high burden of morbidity and mortality. Individuals should be screened based on prevailing risk factors whenever possible. Beyond hypertension and diabetes mellitus, those with sickle cell, HIV, and all other forms of CKD, including APOL1, that we now know is rife in West Africa and is very high in my own country and in my own region of the country. We should, indeed, for me, if you ask me, every Igbo person in Nigeria should be screened, because we have like 40 to 50% high risk APOL1 in that population. Risk scores and risk assessments should precede the biomedical tests. GFR and ACR, that is albumin creatinine ratio, are preferred screening tests. However, in settings where we don't have ACR or PCR, we can use urine dipsticks. And I also recall Richard Houghton, I'm sure some of us can recall, in this the World Congress of Nephrology, South Africa, 2015, where he said we should devise simple, effective, reportable protocol that work for our population. It should come from us, devise what works for our population. I'm happy we're doing that, because if I remember the position paper we put together, we're already doing that. So to plan to screen everybody, since everybody in LMICs, especially sub-Saharan Africa, indigenous populations, are at risk, really, for those populations where the risk is high. We should look at population-wide screening. We should leverage existing health structure and systems and other established programs. So, and no population should be left behind. Thank you very much.
Thank you so much, Ifeoma, for this wonderful lecture. And yes, no one should be left behind, and no population should be left behind. And of course, there are many questions and many options for this screening, and we need to discuss it a lot. So please stay with us till the end, because we will keep the questions and answers to the end. So please stay with us. And me and Ifeoma actually have been together in the World Kidney Day Committee, the ISN-IFKF committee, for about 2 or 3 years now, and we have been a lot together in the World Kidney Day activities and the editorials and all the preparation for all the worldwide World Kidney Day activities. And of course, she's an activist for the renal, for the prevention and for the kidney prevention, and she is continuing in this work in the Afran and in the Africa and worldwide. Let me share my screen now as we move on now to Professor Ranga. Would you please help me in this? Sorry.
It's Vijay Vikrama.
Okay, from Sri Lanka. And Professor Ranga is a professor of clinical medicine at the Faculty of Medicine, University of Colombo. He's an honorary consultant nephrologist at the National Hospital of Sri Lanka and the National Institute of Nephrology, Dialysis and Transplantation in Colombo. His main interests includes the AKI in snake bites, epidemiology of chronic kidney disease and chronic kidney disease of unknown etiology. Currently, he is the chair of the I3C working group of the CKDU of the ISN, and he is the president of the Sri Lanka Society of Nephrology. Professor Ranga now will be talking to us about the CKDU and who is at risk. The floor is yours.
Yeah. Okay. So so I'll share my screen. So can you see my slides?
Yes.
Okay. So thank you, Dina and Valerie, for inviting me to give this talk. And so basically, I'll be talking on CKDU and who is at risk. So so I have no disclosures. So this is the outline of my talk. So it's mainly of 2 parts. So the first part of the talk, I'll be talking about the global burden of CKDU. And then in the second part, I'll talk about why is CKDU important on the global public health agenda. So first, moving on to the global burden of CKDU, the disease, this particular disease was first recognized in the early 1990s when clinicians observed marked increase in the number of CKD patients in certain agricultural communities. And the disease was first recognized in two countries, two regions, I would say, in the same time, in Sri Lanka, as well as in mainly the paddy farmers in Sri Lanka and among the sugarcane workers in Central America. And interestingly, these patients didn't have the traditional risk factors for CKD, such as diabetes or hypertension, and they didn't have conditions such as glomerulonephritis or genetic causes. So, in addition, the proteinuria, which is the standard, manifestation of any CKD, was absent of low grade in these patients, and most of them presented at fairly advanced stage with shrunken kidneys on ultrasound scan. And whenever the biopsies were performed in these patients, it showed chronic tubulointerstitial nephritis. And in view of these disease mainly in agricultural communities, different names were used, such as chronic interstitial nephritis in agricultural communities and CKD of non-traditional causes. And so these are some of the names that are being used. So, one important thing at the outset is to recognize that CKD is not CKD of unknown cause. This is important because in any CKD registry in the world, you have a group of patients where the cause of CKD is not known. And this is because either the patients present fairly late, so you can't do extensive investigations to identify the cause, or despite extensive investigations, particular cause is not identified. So this group is not CKDU. So CKDU is a group of is a condition which is confined to specific geographical locations in the world, where CKD patients are discovered in large numbers. And there are certain common characteristics, such as male preponderance, young age. They are generally workers living in agricultural communities, etc. And then because of this common phenotype, it's likely that they have a common etiology. So it's important to recognize the difference between these two conditions. So when you look at the global hotspots of CKDU, there are two main areas or regions where we find the disease at the moment. This is the South Asian region, predominantly in Sri Lanka and India, and also in the Central American region. But in addition to that, which is depicted in lighter color, is the areas where you have found certain cases of CKD, but whether they are really hotspots, we don't really know, because either these cases are reported as isolated cases or they are reported in small studies. So we need more work in these areas to identify whether there are actually other hotspots in the world. So the disease is more or less prevalent in most of the tropical countries in Asia, Africa, and Latin America and South America. So I will briefly discuss about the disease in main hotspots in the world. So when you look at the Central America, it's known as Mesoamerican nephropathy. And as I said, it's reported since 1990s, and generally the disease is found in the Pacific coastline, from Guatemala to Panama. So the involved countries are Guatemala, El Salvador, Nicaragua, Costa Rica, and Panama. And it involves mainly the sugarcane workers, but also involve other workers like cotton and corn workers and shrimp farm workers. And the interesting thing is it generally involves males and in the young age group from 20 to 50 years, whereas traditional CKD you expect in old age groups. And the disease was first recognized because when you look at the age-specific mortality rates to CKD in Central American countries, you see that there's a striking increase in CKD in age groups between 40 to 60 in certain Central American countries like Nicaragua and El Salvador. So this was the thing or the observation that made researchers look into this particular situation and find what's the reason for this increase in number. And moving on to Sri Lanka, the disease was recognized in the same time in early 1990s, and mainly involving the north central region of the country, and again involving the agricultural communities, male paddy farmers, and all involving young and middle-aged individuals. And when you look at the different CKD cases per 1,000 persons in different provinces in the country, when you look at the North Central province, there's a striking increase in the number of CKD cases, and this is because of CKD-U. And more recently, attention has been moved to India, where we recognize regions where CKD is recognized. First recognized in Udanam region in the Andhra Pradesh, which is in the southeast region of the country, and more recently, the disease is found in other places in the country as well. However, the disease is more heterogeneous in India, and it's not very clear with all these places you have CKD-U, or whether there are clusters where the CKD is not adequately investigated to find whether the causes are some other reasons. So moving on to risk factors, the most intriguing issue with CKD-U is that we don't really know the cause. And worldwide, there are two main groups of risk factors that have been kind of identified as predominant risk factors for CKD-U. One is heat stress and dehydration, because most of the individuals who are affected are workers who are involved with prolonged hours working, and also exposed to significant heat stress and dehydration. And in Central American region, this is considered to be the main drive behind CKD-U. The other main group of causes are the environmental nephrotoxin. So there are many cases, many causes such as silica, heavy metals such as arsenic, lead, or cadmium, then agrochemicals such as weedicides and pesticides, then water quality leading to high fluoride and hard water. So these are some of the associations or some of the risk factors that are being considered as causes for CKD-U in different regions. However, not every individual in these high-risk regions gets CKD-U, so it's likely that there may be other predisposing factors such as genetic causes and low socioeconomic status, and so therefore it's not very clear why CKD-U occurs in certain regions, and even in these regions only certain individuals are affected. Okay, so now we move on to the second part of my talk. This is why is CKD-U important on the global public health agenda. So if you look at the population density of the world, CKD-U affects areas of high population density. So if you look at South Asia specifically, more than 25% of the world population live in South Asia. So although the numbers may not be that much, it's an important public health issue in years to come, because it's affecting areas with large population density. Then, if you look at the areas affected with CKD-U, these are mainly the lower middle income countries. So these are the areas where the disease is more prevalent, and these are the same areas where the resources are so much limited that they cannot handle this disease. So if you look at the total health expenditure per person, these are the areas which have the least, who can spend least. So for example, if you look at South Asia and the Central American region, the per person health expenditure per person is between somewhere around $50 to $500 per year. Whereas if you look at the high income countries such as Western Europe, North America, and Oceania, the per capita health expenditure ranges from $4,000 to $8,000 US. So you can understand the discrepancy. Then moving on to the next slide. So again, if this is the world map where you can see the global prevalence of treated kidney failure, and as you can see, the some of the CKD affected areas, you don't even have data on treated kidney failure. So most likely, these are the areas where the CKD prevalence is so high, there is least prevalence of treated kidney failure. In other words, they have least facilities to manage these patients. And if you look at nephrologists per million population, so the blue bars indicate the nephrologists per million population, and you can see that in Central America, South Asia, Southeast Asia, and Sub-Saharan Africa, it's between 12 to even 2 or 3 per million population, whereas in Western Europe, North America, and Oceania, it ranges between 15 to 25. And again, if you look at access to kidney replacement therapy, which are depicted in the orange bars, you can see in Western Europe, North America, and Oceania, about 25% of the population have access to kidney replacement therapy, whereas this is between, even less than 10% in most of the regions affected by CKD. So you can understand the problem. So CKD is affecting areas which are the poorest regions in the world, and they have the least ability to tackle this disease. So what I'm trying to say is that CKD and poverty are intertwined. So CKD leads to poverty as well as poverty leads to CKD, and also poverty leads to poor CKD management. So impact of poverty on the incidence of CKD. So why poverty affects CKD? One of the main reasons is that because in the low income settings, occupational exposure leading to CKD is higher, because these people are involved with labor intensive agricultural work under extreme environmental conditions, and they are therefore exposed to significant heat stress and dehydration. At the same time, these individuals are involved with more hazardous agrochemical practices. They lack personal protective equipment, and they have extended exposure to these agrochemicals, leading them at higher risk of developing the disease. Then they have limited access to safe drinking water and food, and these food and water contaminated with agrochemicals and heavy metals, and they have high levels of calcium, magnesium, and fluoride in this water. And we can't forget the fact that these poor regions have low level of education, and therefore they have limited awareness of risk factors, preventive measures, importance of hydration, and safe work practices are not, they are not familiar with these. And then finally, maternal malnutrition is very prevalent in these regions, and we know that reduced nephron mass in offspring can predispose to CKD in later life. So this may be one of the reasons why the disease is more prevalent in these low resource settings. So again, CKD is affected by poverty. At the same time, poverty affects the management as well. So as we know, these areas have limited access to healthcare facilities. Most have inability to afford treatment because there is high cost of dialysis and transplantation. It's not freely available for most of them. And there's scarcity of healthcare providers, as I mentioned, shortage of nephrologists and other specialists, and poor access to medications, lack of preventive care. And Fiona was talking about screening and early intervention, which is hardly there in these settings. And then there's inadequate infrastructure. So therefore, the patients who are affected continue to expose themselves to contaminated water. And there's a reliance on traditional and alternative medicine because they are cheaper and freely available compared to Western medicine. And then finally, these individuals also have plagued with malnutrition and other comorbidities which affect the management of this disease. And then CKD in turn leads to poverty. So why is that? Because these individuals are usually the breadwinners of the family because they are young male workers, and when they become ill, they lose their livelihood and they become they get overwhelmed with poverty. And then the high cost of treatment worsens the poverty because they had to there's a lot of out-of-pocket expenditure to medications, dialysis, and travel expenses. And then because not only the patients are affected, then you get their children affected as well, because they had to leave school early and they end up engaged in work and also care for sick relatives, and they lose access to education and more likely to end up with high-risk, low-income occupations themselves. And finally, this all end up with increased debt and families resort to selling assets and borrowing money. So this is a socioeconomic catastrophe. So how can we overcome this issue? I think we are very clear that this particular condition is affecting the low resource settings, low income countries, and it's going to become increasingly worse with time. So we need to strengthen the healthcare infrastructure in these regions by trying to increase the availability of nephrologists, early diagnostic services, and affordable treatments. So if this is easier said than done, and then you have to enhance the preventive care, improve occupational safety through education, and ensure access to safe water, and promote education and awareness, and specifically in relation to CKD risk factors, safe agricultural practices, importance of hydration and regular health checkups. And very important to collect research, through research to collect data, because that will be important to understand the causes of CKDU, because without knowing the risk factors, it's very difficult to tackle this disease. And also we need to look at the impact of the disease and also the socioeconomic factors contributing. And finally, we need to advocate for CKD to be prioritized in the global health agenda, encouraging governments and NGOs and international bodies to allocate resources for CKD prevention, research, and treatment. So, in summary, CKD disproportionately affects agricultural communities in low and middle income countries, primarily in Central America, South Asia, and Southeast Asia. And young male agricultural workers are particularly vulnerable. Heat stress, dehydration, poor water quality, occupational exposure to agrochemicals, and poverty are key drivers of CKDU. And CKD is prevalent in some of the world's most populous and poorest regions, exacerbating public health challenges in countries with limited health resources. Therefore, CKDU need to be prioritized in the global health agenda. And thank you very much. And I'm happy to answer any questions during the discussion.
Thank you so much, Professor Renga. And we have an Arabic proverb which says, translation, like, the misfortunes do not come singly. So this is a vicious circle, what we're talking about for chronic kidney disease and for the consequences of the chronic kidney disease in the limited resource settings. And also we will keep the questions for the end. Valerie, are you with us? Okay.
Yes, thank you, Dina. Thank you. And thank you, Ranga. That was fantastic. So now I guess we'll switch to Dr. Natachai Sri Sawat, who is an intensive care nephrologist from Thailand and is actually a leader in global acute kidney injury, very involved with the ADKI, Acute Kidney Injury Global Consensus Guidelines. I recently met him at a pregnancy-associated AKI guideline meeting, and he is doing fantastic work in Thailand. And I think what's really interesting in Thailand is how much the nephrologists are so also aware of all the health economics and all the necessity of data in order to advocate well. And so I'm very, very looking forward to hearing Dr. Natachai speaking on the burden of AKI in resource-limited settings. Thank you very much for joining us.
Thank you very much, Valerie, for a kind introduction. And also thank you, the IFKF committee, for inviting me to present our research during the past 10 years on the AKI. So my topic about the burden of AKI in resource limited setting. This is the outline of my talks. Starting from the incidence of AKI globally, as you can see that normally the incidence of AKI in the developed or high-income countries has, as you can see, ranging from 20% and up to 30%. But surprisingly, that when we look into the data from Africa, South Asia, and also in some part of America, Latin America, show quite a very low incidence of the AKI. So this means that there are the prevalence or the incidence is may underestimated or underreported. One of the clues that mostly of the AKI in this region is a community acquired AKI, and sometimes it's quite difficult to detection. So the prevalence of AKI in resort limited setting may underestimate, as you can see from the recent data in Lancet and also Nature Review of Nephrology from the previous slide. The reason is maybe we have some limitation of the lab testing, including the serum creatinine, and also some data is not available in terms of the lack of reported. So, but we also know that in the result limited setting, the geographic is quite important, and in this region we have quite a variation of the economics. In the wealthy area, we found that the characteristic of AKI is quite similar that we found in the high income countries, but also in the remote area or in the small city. In this setting, the characteristic of AKI is quite contrast, such as the more predominantly of the community base or the hospital base, and also the AKI sometimes affected in the young age group. And also in terms of the incidence of AKI in this setting, also main confounding by the environmental factor, socio-economic, limited process of care, and some unique exposure. That brings into our recent cohort, already 10 years, we call the CAKI registry, that we conducted prospective data from Thailand, Laos, and Indonesia. We have collected the ICU data in more than nearly 7,000 patients, and this also supported by the ISN, APCN, and also Thai Kidney Foundation of Thailand. And with this kind of the registry, we can establish the AKI epidemiology in Southeast Asia. In Thailand, Indonesia, and Laos, as you can see that the incidence of AKI, this is the data from the ICU, can be up to nearly 50%. Also surprisingly that most of the AKI staging in ICU in this region predominantly in the same way as the more common in the stage 3 or the severe stage. And this data is quite contrast to the data from the Western world that mostly the common stage of AKI is stage 1 followed by 2 and 3. And this maybe reflect about the delay of the AKI recognition and also maybe the delay of the ICU admission. As you can see from this table that most of the patients who got on the first day of ICU admission, they already reached into the maximum stage or AKI stage 3, more than 85%. And also in the characteristic of AKI in this region that we found is sometimes they not only the standalone AKI, but they also have some organ failure such as acute respiratory failure. For example, in this the data also from CAKI registry show that at least 40% they have dual organ failures, and in this dual organ failure also relate to the higher of severity. In terms of the risk factor, we found that some specific and interesting risk factor for AKI in this region, such as in Thailand, the anemic is become predominant, overweight and obesity in Indonesia, and in Laos, not only the overweight and obesity, but percentage of fluid accumulation and diuretic use is a risk factor of AKI. In terms of the etiology, the predominantly etiology of AKI in Thailand is sepsis, occupy nearly 50%. Indonesia in the same way, but surprisingly also in Laos, not sepsis, but renal hypoperfusion that might reflect about disease related such as severe diarrhea, and that might play a predominant role, and this might reflect sometimes the risk factor that we can modify. In terms of the specific etiology, this is data from our recent review in nephrology. In this region, not only we also have some unique feature or the cause of the AKI, such as some plant and herbals, and also some specific fruit that can damage to the kidney. And also tropical infectious disease causing AKI in this region, also one of the major burden in terms of economy. The top three including the leptospirosis, dengue, and the malaria. As you can see that the leptospirosis, one of the major tropical infectious disease in this tropical zone and also in our region. In some, normally the AKI can develop in this setting around 30%, but the report in some data, such as in this paper, show the AKI incidence can be up to nearly 84%. The mechanism, including the direct toxicity by the migration of the leptospire bacteria and also by indirect toxicity, including the liver dysfunction, high bilirubinemia, and also severe leptomyolysis that can cause kidney failure in this mechanism. We know that to prevent this kind of the leptospirosis death, we need to have something like early detection, early referral, and also early organ support. And our group has also studied the leptospirosis disease for more than decades, and we have nearly collecting the biobank of the clinical sample, include the history of patient for more than 1,000 cases for now. We have tried to emphasize that the early detection is quite important, and with the current point of care testing that we have, they have a lot of limitation of sensitivity and specificity. This is a report that we show that in some tests, they can only sensitivity only 4% to detect the acute leptospirosis. We try to improve that kind of the detection by develop some simplified score that we call TILEPTO scoring, both the inpatient and outpatient setting, by using the clinical symptom and also plus with the simplified laboratory that most available in the small community hospital. And this kind of lepto score will allow us to early detection of leptospirosis and move them to the higher level care if they need it. We also develop some point of care testing using a little bit sophisticated technique we call the CRISPR-Cas that will allow us to detect the part of the leptospire and increase the sensitivity of leptospirosis detection as a point of care testing. With the CRISPR-Cas technique, we can improve the sensitivity of test up to nearly 100%, and this will allow us to early detection of leptospirosis. And also recently, we also report this cohort in NDT, try to emphasize that the leptospirosis associated AKI is not only impact to the short-term outcome, but in this report, we show that in the severe case, they can related to the long-term kidney outcome that including the major adverse kidney event and new onset of the CKD that can increasing after severe leptospirosis infection. And this kind of the data is one of the first few data that we have right now to show the importance of leptospirosis linking to the chronic kidney disease. In terms of the renal support, data from CAKI registry clearly show that the incidence of the RRT rate in this region, such as in Thailand, is still quite lower than the data from developed countries, about only 6% compared to the report from Ivory Coast that show the RRT rate up to 13%. And most of the common mode of support is intermittent dialysis, followed by CRRT and PD. The same thing happened in Laos. The RRT rate much lower than previous report from the Western world, only less than 2%. And also surprisingly that in Laos, they don't have any acute PD or CRT program. 100% of acute kidney injury that require RRT support using the hemodialysis. With the support from the ISN, we have trained the young Laos nephrologists during the past few years as a ISN sister fellowship program. For example, in this figure, the Dr. Saipet from Mitapap Hospital in Luang Prabang, Vientiane, he is graduated from our institute and established the acute PD program for the first time and can rescue the patient who come with the severe hyperkalemia in Mitapap Hospital. Indonesia, the same thing, RRT rate still quite low. In terms of the outcome of RRT, this data from CAKI show the comparable of mortality outcome between 4 major RRT modality, including CRRT, hemo, SLED, and PD. And also data recently that we published last month in CJSN about the role of acute PD, try to emphasize that the acute PD is still very important in resource limited setting and easily to access in some area with the lower cost. We show the comparable of efficacy comparing to standard acute intermittent hemodialysis in acute kidney injury setting. The RRT prescription rate, why is low? Because maybe the limitation of physician in Southeast Asia and Oceania, we are ranking the number 8 in terms of number of nephrologists compared to other regions. And also the limited, another thing is the reimbursement issue, because in the past CRRT is not reimbursement by in the hospital in Thailand. But with the data from CAKI registry, it allows us to work with the HITAP that support by Ministry of Public Health, try to driven the research, cost effectiveness analysis, and the first time that the CRRT can be reimbursement program can be raised and can be funded about 2 years ago with the support by the HITAP groups and with the data support from CAKI registry. We also try to minimize the cost of CRRT, such as to develop some like a custom-made CRRT solution that under production by the standard quality control by pharmacist team. This is also the way that we try to feasible, accessible of this kind of solution to and minimize the cost of CRRT in resource limited setting. Knowledge gap also important. That in Thailand, we have also developed Thailand CRRT Academy program, training more than 1,500 participants from more than 100 hospitals across the regions. As you can see from the map, about 8 years ago, only few regions in Thailand that can doing the CRRT traineeship program. But after the program implement, we have covered for more than 70% of the country to be trained with the CRRT training program. We also access to other countries, such as develop the Vietnam CRRT Academy program to train the intensivists in Vietnam also. And also we try to develop and raise our young nephrologists and intensivists who are interested in the field of critical care nephrology by create the fellowship program for 1 year. And we have trained around 10 young nephrologists and intensivists already with this program to serve for the people in the rural area or in the remote area. And now we are also just finished the study, try to understand about the long-term outcome of the AKI patient. And we just finished the enrollment of the patient. This data will represent the data from Thailand, Vietnam, Malaysia, Indonesia, India, and Singapore. This is some data from our preliminary results. And also we try also to develop the post-AKI clinic by using multidisciplinary care team approach, try to provide a better care for our post-AKI patient also. So in summary, that the global of AKI burden still, I think the impact is still a lot. And maybe the way to improve that, we may use the 5R approach, starting from risk assessment until the end of try to improve the recovery of the kidney function. That is the thing that we have done so far. Thank you very much.
Thank you so much, Natasha. This was really inspiring, and this is a huge work, and this should be really a model for many. Thank you so much, and thank you for all the speakers. And I think we should move now for the questions. And
quite a few questions in the question answer box. I think the first one is for Ifeoma.
yes, so I think the first one is for Ifeoma, and is the what about the
read it out?
Sorry,
Shall I read it out?
can you hear me?
Can you read it out? Yeah.
I would read it, yes.
Yeah.
Can you read the question?
There was on the chat a question on the chat first for Ifeoma about the cost effectiveness for the screening in the low and the low middle income countries. So would you like to comment, Ifeoma?
Oh, sure, I would love to. I want to know the cost effectiveness of screening in low and middle income countries. Like I showed, there are various strategies. If you know your risk factors, that is the cost of CKD in your area, you can screen those with risk factors. But the problem we have in most of the low and middle income countries is that we don't even know the risk factors. I'll take you back to when I was doing the screening in 2006 and 2000 and whatever for ISN. At that time, there was nothing like Apple One. I noticed that the people I screened in the rural areas, even though they did not have more prevalence of hypertension or more prevalence of GM, they had more CKD than people in the urban area, right? What was responsible? Obviously, it wasn't the hypertension, it wasn't the DM. So there are factors. So if I'm going to screen just hypertension and DM, I won't be getting all those people. So it depends on your population. If you're able to find out what the risk factors are, you can screen that for the risk factors. If you don't, then you probably begin to think of, and you have a lot of people coming with kidney disease, you have to think of screening maybe that whole population to be able to get the people. The important thing is getting the people. I know the cost is very, very important, but in our areas, we don't quite know the cost, but I don't know. You must do something. That's what I believe. Even in your little area, urinalysis can trump up a lot for us. Yes, simple urinalysis, we can do that. And that is cost effective, isn't it? How much is urinalysis, the strip? You know, instead of doing nothing and resting on our hours that, okay, it's not cost effective, we can't afford it. Simple urinalysis we can do. If you add on creatinine, that makes it even better.
Thank you, Ifeoma. Yeah. That's very passionate as always. And I think one of the questions you mentioned is urinalysis, but I'm wondering, Natachai is definitely one of the leaders in terms of point of care. I think there's a question both from Sarah Lanaiker and from Bogdan Mihailovic in the chat about the utility. At least Sarah is asking about point of care. I think how do we take this to the people? Because point of care at the moment is extremely expensive, and some people are a little bit hesitant because of the lack of sensitivity, etc. Natachai, I wonder if you could elaborate a little bit. You mentioned in your AKI, but I know you've worked on this as well, a bit in CKD, I think.
Thank you, Valerie. So I totally agree that the screening is very important. The thing that we try to do, this thing is also we try to develop the test, but not like a point of care that been tested in the hospital setting, but we develop the point of care that the home-based use. The idea is the same in the COVID period, that all people can access to the COVID test by the home-based technique. So in our idea or our opinion, we think the CKD screening is not only limited in the hospital setting, but we try to develop the point of care testing as a home-based. As you can see that also recently there is some data from Thomas study groups in Lancet that show some cost effectiveness of the home-based use for early CKD screening. Even this data from the high-income countries, but I think this also emphasizes that we should test the same thing in result limited setting.
But are you testing albumin or creatinine at home?
We use the specific monoclonal antibody to albumin that is developed in our university. That will more specific than the dipstick, because the data that we found, the dipstick only sensitivity only 30%, comparing to the specific monoclonal antibody to albumin will increase the sensitivity up to 80% for albumin detection.
No, fantastic. And I think one of the huge questions is going to be the cost, and how does one afford this at a whole country level? And there maybe some of the participants might actually have more to say. But over to you, Dina, or to the others to ask questions.
I think many of the questions about the point of care.
I just wanted to say that I was born in Sri Lanka, and I know the challenges that we face in our countries. And in India, what we are trying to do is do screening at the basic level for NCDs. Now they've started finally concentrating on NCDs. And so all public health centers have got an NCD kind of desk, where they have a BP machine, a blood testing machine, and hopefully a creatinine, a blood, with a drop of blood to take creatinine as well. So wherever the public health centers are, they are trying to make it mandatory that all of them do a screening for whoever walks in for any of the any ailments or any of the medical help that they need. So I'm sorry. I mean, Doctor may have a few more words to say on that.
Thank you, Lata.
If I can add a word on the point of care, I think point of care is the way to go. It's a thing for the future. Now it's very expensive, but it's going to get cheaper because it makes screening easier for us. You don't have to carry samples because the screening is actually done in the community in some areas at the primary healthcare level. That's where it should be done, not in the teaching hospitals or whatever. If they come to you, yeah, you can screen, but most people go to the primary healthcare centers. That's where they are seen. So using the point of care is going to definitely help. But the point is that the point of care is very expensive now. Maybe it will come down with being used often and many people using it, just like every other thing. When there's more usage, the prices come down. So I think point of care will have its value and its use in not too distant future. You can not just using blood now, they are talking of using saliva for creatinine and all that. All these things in future we'll be able to use them. Because I recall when the glucometers were introduced, everybody were like not too sure what this is going to do. But who talks about taking samples these days? So it's glucometer everywhere for research and all, unless you specifically want to do something different. So I think that's where we're going with the point of care for all the other things. Thank you.
Thank you, Fioma. And there's a question for the pediatrics, but before we move on to this question, there was to continue with this point, that as we can see, a lot of countries, even developed, do not have enough nephrologists to match the CKD burden a number of patients. Is there a case for amplifying the primary healthcare workers to be the first line of care for the chronic kidney disease? So I think this somehow goes along with what you have just mentioned now. So, Valerie, if you can read the first question about the pediatric population.
Well, I was actually wondering if we can stick to this point of care just for now in the primary care. I was just wondering with Iranga, Sri Lanka is a country that has organized primary care, right? As far as I understood. So how are you actually screening for kidney disease? And we'll get to the children in a minute, but how are you screening for kidney disease in Sri Lanka? Well, since you have, as far as I've understood, some sort of national or universal health coverage.
So Valerie, the CKD screening program in Sri Lanka actually started with the discovery of CKD-U, because that was the kind of the highlight of the CKD. I mean, because obviously the CKD epidemic started in the North Central province, and with that there was a lot of attention to CKD, and so much so it's gone to the other extreme now. So everybody's thinking the only CKD we have is CKDU, and there's less attention paid to other NCDs like diabetes, hypertension causing CKD, which is more overwhelming than CKDU in Sri Lanka. But it has done its kind of whole kind of benefit, because most of the countries, even from ISN, we got a lot of support to develop CKD screening in Sri Lanka, and so much so that we have a separate unit in the health ministry specifically targeting for CKD screening. And they have a lot of facilities specifically based in lots of hospitals where they have vehicles, staff to utilize urine albumin creatinine ratio and serum creatinine with portable laboratory services and things like that. So much so that that's developed in a big way. But the question we have in Sri Lanka is how to utilize these resources in a most cost-effective way. And at the moment, lots of areas in CKDU regions are being screened, but we get very low yield, whereas you have so many other areas in the country plagued with hypertension, diabetes, and other NCDs, where we have more prevalence of CKD, and we are not screening these areas. So this is the problem. So we need to, as Ifeoma said, we need to identify the high-risk populations and then focus our screening to these areas. And I think that's where we need to kind of focus on.
So that's powerful. Again, we're forgetting the causes in your setting, right? Because of the hype about CKDU. But did I understand that you are then using point of care in general, these outreach teams?
Yes. So basically, they have portable laboratories set up inside these vehicles, and they go to these places and screen, take samples, and do the analysis in those labs. And they provide the results. It's more like a point of care thing, but it's more like a portable lab-based kind of a thing. Okay. It's not like what Natachai was explaining, like more of a strip-based or like point of care testing. But however, the purpose is served. But again, we need to make it more cost-effective, because we were donated with a lot of these equipped vehicles by some countries, but now we have to buy the reagents from these countries, and that's very costly. So again, we have to be very clever and intelligent in utilizing these screening kind of techniques.
So I come back to the cost effectiveness of this and how to collect the information and collect the data from those screening, because if they are just individually done, then we will still be in like all the graphs that you have shown today, whether it's for the CKD or for the AKI, that there is a deficiency and shortage of data from the low resource setting income, or from the low income countries. So yes, we are trying to do a lot of effort, maybe collecting donations, maybe doing some efforts, every center on its own, but still this lacks the data, and this has to be organized definitely with the health care resources and with all the ministries and all this stuff, because without this there will be no continuity and no data. What do you think? I'm just thinking loudly. How could this help with the data collection?
I think Thailand proves
on a country level. I mean, on a country level.
You mean the screening and stuff? Okay, sorry. What the question was to me or to any one of us?
Oh, I knew you.
Yeah, I think if we have a well-established program for screening, obviously when you collect your data, you're going to, analyze it. And in fact, part of one of the things we were talking about, Valerie knows about that. We were talking about some team that wanted to start off screening and wanted to have it done in maybe a part of our population. And I was saying to that team that what we actually need in our countries is a prevalence study where we are going to look at the whole country, pick some areas, properly designed study where you can get a prevalence study, right? That is different. But for the screening, if you're screening for the whole country, of course, your data, if you keep your information, keep your data and store your data, have a database to put all those things, soon you'll be analyzing and having prevalence of kidney disease or hypertension or what have you in the different areas of your country. Yeah, and these days it's easy there are simple databases one can use. You can use SPSS, you can use RedCap, and there are so many of them that you can use to store your information, and that data will soon be coming out from everywhere. I'm seriously hoping that we can do that for Nigeria, and soon we'll have a prevalence of kidney disease in Nigeria for people to see. Unfortunately, for the global kidney health atlas that we do, the response is not so good. So you see that probably that's where they got to 1.7 for AKI in Africa, where every pregnant woman virtually has AKI because he has some problem as he's having the baby, So, the documentation is seriously flawed. But let's leave it for another day because let's leave that talk for another day. But just know that documentation is flawed. Yeah. Thank you.
Yeah.
And I think we've just seen so beautifully presented from Thailand that how much progress you can do when you actually have numbers. Obviously they're fantastic researchers, Dr. Natachai and his teams and everything, but they couldn't move and couldn't even start the research projects without knowing what they were dealing with. So I think, Natachai, you obviously have a fantastic system there with collecting data.
Yep. Thank you, Valerie. Our team also try to do like a long-term cohort of early CKD screening in to be the model for we start to screening the people in the village when the time that they don't have any symptom of the CKD, but they are the high risk, such as the people who have age more than 65, diabetes or hypertension. This is a group that we are focused, and then we screening by our home-based screening test. And if the test become positive, we then go to confirm by the standard test. But if the test negative, this test is kind of a very strong negative predictive value. So that should be safe to follow them for another for the next year. So and also our Ministry of Public Health try to improve the screening program. Now they are undergoing to do the cost effectiveness analysis. But to keep in mind that the CKD is quite a long-term disease, so sometimes we cannot wait until 5 or 10 years, but we need to have some a special model to prove that. So if the thing show the cost effectiveness of the screening program like our home-based test, the Ministry of Public Health have planned to provide this test to the pharmacist, to the drugstore or any superstore or convenience store to allow all the people in Thailand in the high risk group to screen for CKD. That is a strategy that they want to use.
Perfect.
Let me just make a little comment concerning this cost effectiveness we are talking about. If we attach treatment to screening, there's no way it's not going to be cost effective. If you identify somebody early who has proteinuria and maybe needs ARB or SGLT2, and you start it early, that person is not going to end up in KRT. It's not going to end up needing kidney replacement therapy, not in the near future. I may never even need it until he passes on. So there's no way. All we just need to do is maybe put the figure down, and it's going to take time. But reasoning it out, just simply reasoning it out, you can see one single person with KRT needs how much. I can't even afford to be on kidney replacement therapy because I'll die off. I cannot afford to pay out of pocket. And that's what we do in Nigeria. We pay out of pocket. Simple. So that cost effectiveness thing of talking about, once it's tagged to treatment, you identify, stop it going on, the person is treated, it is cost effective until proven otherwise.
Yes, this needs a lot of advocacy and collaborations actually, because to deliver this message for whoever taking decisions or managing this needs a lot of work. It sounds simple, but on the ground, especially in the low-income countries and like in Africa, and it's not that easy and not that straightforward. So I hope that maybe in the coming years, this message will be widespread and understood for many, that it is cost effective in the end, not just looking on today's cost.
Exactly. I think, Valerie, maybe you should answer the question on pediatrics. You said something about the pediatric question. It's asking about
also
protein creatinine.
Just one tiny question about cost effectiveness is it's not only money. In places like Africa, it's death, you know? So it's not only money that we have to think about. And I think the question about children is important because here today we're trying to not leave populations behind, and the children very often get left behind. I think, as was mentioned in the question and answer there, obviously a pediatrician knows what they're talking about. The children have different forms of proteinuria, so you may miss it with a general protein to creatinine ratio. But I think also, as you were saying, it does begin in the womb. And if women are going to antenatal care and they're actually having ultrasounds, maybe we can pick up some children, especially the boys with the posterior urethral valves that are fixable.
Exactly.
You know, we could pick up some of these children in the utero and then make sure that postnatally they're followed, they're intervened, you know, they get simple treatment there as well. Or children born, you know, with one kidney that are looked after for their whole lives from childhood, etc. So I think, again, this just shows the holistic approach that is needed, because kidney disease pops up everywhere. Everybody's at risk, and we have ways of diagnosing easily, as Ifeoma showed. We have now very effective therapies. Those need to also become affordable, because they're also not affordable in many places, out of pocket. And then finally, obviously, if we get more sophisticated, you know, as people, some people do progress regardless, we get to obviously need the tertiary care. And then I think, as Iranga just showed, you know, this idea of detecting hotspots. How do you detect a hotspot? You have to make a diagnosis. You have to screen. You have to collect that data and realize there's all these people in this one area. So I think this has been, for me, a fantastic, I don't know how much time we still have, but I think it's been a fantastic, really, you know, ringing a bell that we do speak a lot of rhetoric in all our advocacy about CKD, but very global and very high level, which is important. But we have to get down to the granular level and understand there's so many unmet needs even within that, you know. So for me, I thought it's been a phenomenal webinar, and hopefully it's taped and we can now somehow disseminate, you know, because I think it's been fantastic. It's been brilliant. And the 3 talks for me were like fantastic. Yes. Really brilliant. So thank you so much.
Thank you so much.
And what Ranga has mentioned, that it's the poverty and the low income, that they are more predisposed to the chronic kidney disease, and those who are the ones who cannot afford the treatment, and then they lose the jobs, and then they go to more. So actually, it's like a vicious circle. And we have to work for just interrupting this. Thank you.
Fantastic.
Thank you. Thank you all for those fantastic, inspiring lectures from everyone. And for, of course, Valerie, for her always, for the support and for her contribution for everything, and connecting people. Usually I say Valerie is always connecting people. So thank you.
I just know who knows what they're talking about, and that's when I suggest them to speak.
So on behalf of IFKF-WKA, I just want to say thank you all. Look out for our next webinar. We have Dina, who is a fantastic organizer and who gets people together. She's our secretary, and we're going to have one very soon in September. I thank Nirmala, Kripa from Tanker office as well, and Kausi, who've all been helping us put this together. I'm sorry there were a few glitches, but we will sort it out for the next webinar. So thank you, each and every one of you. It was absolutely enlightening. And it's not just for low income, I think middle income, high income, we should not leave anybody behind. So we just need to be watchful and do our best. So thank you all very, very much. Dina, you can say good night.
Thank you. And if anyone would just say
Okay.
one closing word before we close. So we start with Ifeoma.
Well,
Closing word.
I reinforce no population should be left behind. We should, as the nephrology community, make sure we bring everybody together. We carry everybody along and make sure that nobody is left behind. It doesn't have to do with money. There are other ways we can help people and make sure that we stop kidney disease at its roots and make sure that WHO also prioritizes kidney disease. And that's where we're headed. Thank you, everyone, for listening. And thank you, the organizers, for inviting me.
Thank you. Thank you for joining us. Dr. Eranga.
Yeah, anyway, thanks, Valerie and Dina, for giving me this opportunity to talk. I think one of the key things about CKD and, specifically on CKDU is that I think the key thing is we need to enlighten everyone regarding the importance of CKDU, but at the same time, not, recognizing the importance of, working up patients with CKD rather than just assuming they all have CKDU. And I think that's the key. I think now what's happening is that most parts of the world, you just identify individuals with CKD and then without working them up, you just label them as CKDU, which should not be the case. So I think we need to work a lot on these areas and screening, as well as once you're screened, once you identify patients, how do you work them up and how do you refer them for treatment and things like that. So I think it's a lot of things you can do as a group to educate the nephrology and as well as the general community on these aspects. And thank you very much for giving this opportunity.
Thank you. Dr. Natasha?
Oh, yes. I just would like to echo all the Professor mentioned, and also I just would like to emphasize the role of education, like in this kind of the meeting, the IFKF-WKA. I think this is very useful, very important for us to keep update on the new knowledge of nephrology. And I think we still have a lot of things to do and to overcome for the next near future. Thank you very much.
Thank you.
Valerie, I hope you'll be part of all our programs. Thank you. You're a great moderator.
Valerie? You're mute. You're mute.
I think I've said enough. Thank you so much.
Bye, everyone.
Okay, that was so brief. Thank you.
Thank
you so much.
Thank you.
And
Bye, everyone.
Thank you to our participants as well. Thank you.
Thank you.
Bye-bye.